underpins the use of prescription tray therapy. You've got just some basic images here, pre-treatment, post-treatment. This is a case that comes from Dr. Wendy McCrite. She's in Steamboat, Colorado. And on your left, you see this pretty regularly, right? This is a patient in general maintenance having some troubles. All they did was add a prescription tray therapy of a hydrogen peroxide gel. And when you use this tray therapy at home, you can have significant improvements for your patients, and that's what we're about. Our mission is to improve patient health and to help maintain those improvements. As Lisa said, I do work full-time for Perio Protect, the clinical trial and the research liaison, so I have a lot of science for you tonight, but it is all practical. The top 2 reasons for you to take this information seriously is it will benefit your patients and it will benefit your practice. When you ask dental groups around the country what's their biggest challenge treating periodontal disease, home care is their #1 issue. And it is a problem, right? Toothbrush, rinse, and floss don't get deep enough for most of your maintenance patients. This is why 47% of American adults have chronic periodontitis. And let's just face it, if what we were doing worked well, you wouldn't be here tonight because you are looking for a solution to make your patients healthier. The problem, again, has to do with getting access deep under the gums. So your patients come in, they've got an infection and the gums are starting to swell, and you might do some scaling, but then you send them home, the stuff grows back, and you're asking them to brush and floss better or longer. And it's true, some patients aren't doing enough, but even with excellent technique, they can't keep up. The toothbrush, rinse, and floss, it just doesn't get deep enough. So this prescription tray has a seal that prevents the medication from leaking out all over the mouth and will push the medication really deep. They just wear it in 10 to 15-minute applications, and the medication will fight the infection. And the primary antimicrobial that I'm going to talk about today is hydrogen peroxide. And hydrogen peroxide is exciting because it is particularly effective against biofilms. What you're looking at is a scanning electron microscope image of a biofilm that grew on a carrier that had been sterile, was left glued into a 6mm pocket and left there for 48 hours. And then endodontist extracted it, and it was completely colonized within 48 hours. Polymicrobial, dense biofilm. This is why patients struggle at home, because this stuff grows back so fast. The mouth is the perfect incubator. It's warm, it's moist, there's an ample food supply. And so you can do a great job in the office, but patients struggle at home. And so often we try adjunctive therapy that is based on antibiotics. And antibiotics have been the wonder drug against bacterial infections, except that when you are talking about a chronic biofilm-based infection that is prompting this inflammatory response we all call periodontal disease, you have a problem because biofilms are refractory to antibiotics. They're not particularly effective. And when they are effective, the benefits of them tend to be temporary. So let's talk about why. What's wrong here? First, there's a lot of defensive capabilities that the community has itself. And when I'm talking about a biofilm, I'm just talking about a community of bacteria. They're covered in slime. That slime is hard to penetrate. Antibiotics do not penetrate it well. There are 3 substances that can get through the matrix. I'm calling it a slime, but think of it as gooey, sticky slime. Bromine can cut through that, and you're not going to use it. Chlorine-based products can do it, and there's some good chlorine-based products on the market, and peroxide-based products can cut through this. Tonight we're going to talk about 3 agents, chemical agents that you might deliver in this tray. The first is hydrogen peroxide. In a tray that's sealed, it's a really nice option because the bacteria are always moving around the mouth. If you have a tray, you have comprehensive coverage. And in this final stage here, where you see detachment and dispersal, you see the bacterial cells seeding off either as planktonic cells or clumped in slime. This happens all the time. They're always moving around the mouth. And if you have a tray that can seat for the whole arch, you have a much better chance of decreasing the bacterial loads in a comprehensive manner. Now, part of the reason why antibiotics don't work well, it's not just that there's this physical barrier, but conventional antibiotics work against particular species, and you can have really different bacterial species in adjacent pockets. So it's going to be hard to find the right antibiotic. And if you see these bacterial cells, they're all clumped close together. They're all communicating. They're teaching each other intra and interspecies resistances to antibiotics. And you also have layering effects here. So just the general building of the community is going to prevent the effectiveness of conventional antibiotics, because most conventional antibiotics are going to work as cells actively divide. The closer you get into the middle of those layers, the less cell division occurs. The cells are dormant. It's like they're asleep. So for all these reasons, antibiotics are really limited. If we're talking about systemic antibiotics, we have additional concerns. And let's just look at some of the data that came out of a JADA article last year. So approximately 25 million antibiotic scripts are written by dentists each year. And I'm going to let you think about this. What percentage of these prescribed antibiotics, not by dentists, but just in general in the United States, there's 250 million scripts written annually are estimated. But of those, how many are not necessarily or optimally prescribed? It's up to 50%. And if we talk about public health, when you have an adverse drug event that lands a patient in the ER, 1 in 5 of those adverse drug events is for an antibiotic-related event. And it is the main cause of C. diff infections. So I don't think it happens too often, but it does happen in dentistry. This caught my attention in 2013. This is a patient who contracted C. diff after taking an antibiotic for dental work. Nothing was resolving her conditions. She was miserable, and she ended up having to have a fecal transplant. And so back in the day, right, just 4 years ago, 2013, they took a donor sample, put it in a blender, intubated her, and then put the liquid sample down into her gut, because what happens when you have all these high-powered antibiotics is that you can wipe out all the good bacteria in the gut, or in this case, you have an overabundance of C. diff. It worked for her. And it has worked so well for patients that has been in testing since 2013 that now you don't have to intubate and get liquid samples down into the gut anymore. Now you can take a pill. Just don't think about it, what it is. But it is helpful. And so, but this is a real issue. And the point is there are serious side effects when we are prescribing high concentrations or repeated courses of antibiotic therapy. The CDC has had a really robust public health campaign to raise awareness about what they used to call antibiotic resistance, now called antibiotic stewardship. But this is one of their early publications, and if you look right here under the problem, it's called the public health ticking time bomb. And what they're talking about are antibiotics that are, bacteria that are resistant to antibiotics. So this is probably 5 years old, maybe 6. At the time, they were warning the public and prescribers of the dangers of this rise in antibiotic-resistant bacteria. As of February of 2017, there are now 12 known bacterial species that are resistant to all known antibiotics. So we're in that age. And so if you are concerned about these issues, I invite you to give some serious consideration to hydrogen peroxide in your treatment. This is a really low concentration of hydrogen peroxide. This is the gel that you're going to see in the clinical trials, in the big case study on refractory surgical patients, and in the individual case studies. The active ingredient is just 1.7% hydrogen peroxide, and it's purposely kept low so it doesn't cause sensitivities. It is classified by the Food and Drug Administration as an oral debriding agent and an oral wound cleanser. And it's a great broad-spectrum antimicrobial for a lot of reasons. Nobody's allergic to hydrogen peroxide. We're all making it in our liver right now. There's peroxide in human breast milk, there's peroxide in your white blood cells. It's possible that you could be allergic to one of the ingredients, for example, the menthol flavoring, but nobody's allergic to hydrogen peroxide. And right now, bacteria, there's none that we know of that can build up a resistance to hydrogen peroxide, especially in the same way they do to antibiotics. And the peroxide has 3 excellent antimicrobial actions. First, it can cut through the matrix, that layer of slime that covers the biofilm community. It can also debride bacterial cell walls. Hydrogen peroxide breaks down protein chains, and the bacterial cell wall is made up of linking proteins. It'll cut a hole right in that cell wall. I'll show you some images of that. And very importantly, hydrogen peroxide oxygenates the pocket. This is what we think is so important. And just listen, because this is the most important point for the entire presentation tonight. With this prescription tray therapy using hydrogen peroxide gel, you are never going to kill all the bacteria in the periodontal pockets. You're not going to be able to sterilize them. And you don't want to. You want a healthy bacterial flora. But the way that you control the overgrowth and the regrowth of biofilm is by changing the environment so that you put the pathogenic bacteria on the defensive and you encourage the healthy bacteria to grow. So this is all about microenvironmental change using the oxygen therapy. It's safe to use hydrogen peroxide products every day. We're going to go through some protocols here where I'm going to recommend twice a day or once a day, or sometimes in the very beginning, maybe as often as 3 times a day, 10 to 15 minutes. But we recommend this long term. One of the studies here that was published is following refractory surgical patients and followed them out for 5 years, and those folks were recommended to use the tray therapy with the hydrogen peroxide gel every day for those 5 years. So you want to know that it's safe. When whitening became really popular in the 1980s, the Food and Drug Administration started to study it, and Marshall et al., this group down here at the bottom, was the lead on the studies, and they determined, after following patients who used hydrogen peroxide oral care products every day for up to 6 years, that it was safe. There's no carcinogenic activity, there's no adverse effects, and I say it's safe in this low concentration of 3% or less. They also noticed that the patients who used the peroxide products had less plaque and less gingivitis, and so they got excited about the potential to use hydrogen peroxide products for perio. But the problem they identified there at the bottom of the screen is patient access. It's just not easy to get the hydrogen peroxide down deep into the pockets. You need a way that is not technique sensitive. You need a way that is easy, and it has to be comfortable. And that is what the prescription Perio tray does. So the Perio tray is the only tray currently on the market that is cleared to do this work, and this work is to place medication deep into the periodontal pockets. The research shows it can get up to 9 millimeters deep. And it's exciting because it's comfortable, it's easy for patients to do, and it is sealed in a way that makes it different from anything else. So there's a seal on the internal peripheral edge, and that seal is custom crafted for every single tooth. The seal, in combination with the extension, you can see how precisely it fits here in the distal edge. That seal and extension system, it works like a gasket. It prevents the medication from leaking out all over the mouth, and it'll push the medication really deep. Again, it can get up to 9 millimeters deep. Now, how do we know this actually works, right? How do we know that the tray can deliver it deep and that it will actually decrease bacterial loads? So this is one of the studies that was done really early on. It's in the proof of concept article. If you look on your handout, research and publications, look for the proof of concept, because this will be placed in there in part. What you're looking at is a carrier and where the carrier was placed. So the endodontist Paris Segazeta and the dental microbiologist Christophe Chaudin at USC orchestrated the study, and they placed these sterile carriers into 5 and 6 millimeter pockets. And essentially, every time you see the blue square, that's when the carrier was in place, and then when there's no blue square, that's when active treatment went on, and the treatment was just the tray delivery of the hydrogen peroxide gel. So 2 days of treatment, stop, put a carrier in, don't use the trays, take it out, examine it, 5 days of treatment, fresh carrier, no trays, and on. This is called the biofilm potential technique. The actual explanation for why they're doing this study is in full detail in the August issue of JADA in 2009. Essentially, in short, the goal is to find out if treatment changes the potential for the biofilm to recolonize the carrier. So you're looking in the same pockets, and you're looking to see how well the bacteria can colonize the treatment at each of these time points where you have a blue square. So in the first half of the study, they just used hydrogen peroxide gel. In the second half of the study, they used hydrogen peroxide and a doxycycline. So let's look, just easy 2 days of treatment. So this was a 5 millimeter pocket. This is your pre-treatment carrier. This is what grew in 48 hours. They've taken it out to examine it, start tray therapy with the hydrogen peroxide gel for 2 days, put a fresh carrier in. After 2 days of that treatment, you don't have a significant reduction in the number of bacteria, but you have a change in the kind of bacteria. Now you have mostly aerobic bacteria at the expense of the rod-shaped morphotypes. So this is not DNA analysis, it's visual, scanning electron microscopy, and you're looking at the morphotypes, but these are mostly aerobic at the expense of the anaerobic. Now, in a separate pocket, and this was a 6 millimeter pocket, you have a huge reduction in the number of bacteria, but not a significant change in the kind. So the microbiologist couldn't explain this. We can't really explain why in some pockets you're going to have a big reduction and in others you're going to change the kind of bacteria that grow. But over the course of the study, all pockets saw a 90% decrease in microbial counts. So let's look at a different way. This was the case that I showed you at the very beginning. This is a patient struggling, and then after adding tray therapy to your regular office visits. And she used the trays twice a day for 15 minutes and then dropped down to 1 time a day. But you see her pre-treatment. This is an oral DNA test here. You see a pre-treatment bacterial load, and you see post. This is 6 months later. It corresponds to the images you just saw. So again, you're never going to sterilize the pocket. This stuff is always going to grow back. But look what happens when you add oxygen. You have a huge decrease in the high-risk pathogens. And so you need to combine this information, of course, with your clinical assessments, but it is showing a decrease in the bacterial loads. So the researchers brought up, the ones who were originally studying hydrogen peroxide, that the problem was access. So let's say the trays overcome this access, and I have more research to back up that claim. But access is not the only problem. The other problem is therapeutic time. Hydrogen peroxide needs time to work. How long does it need? That depends on the concentration. So if you have much higher concentrations, you'll see a faster kill rate, but you also have patients with a lot more sensitivities. So at this low concentration of 1.7%, your therapeutic time point, the real sweet spot is 10 minutes. We are going to recommend 15, and I'm going to explain all of that right now. You're looking at a live dead dye study from Allegheny Singer Research Institute. This was, I don't know, 8 years ago, when we sent a lot of samples of hydrogen peroxide to the microbiologists at Allegheny Singer, and we asked them to test it. And so they devised their own tests and gave us some feedback. We were looking for the best formulation of hydrogen peroxide, and they didn't know which was which. They were all blinded. And we wanted to know what was consistently working, what formulation had a good shelf life and a good kill rate. In a live dead dye study, you expose the biofilms to the dyes. If the cells pick up green, the cell is alive. If the cell picks up red, the red dye, the cell is dead. So it means that the cell wall is lysed. And your left-hand side image is 3-day-old Streptococcus mutans that's been exposed to only to the dyes, no gel in your untreated control. And the goal here was to see, what's your normal kill rate going to be in an untreated controlled condition. So you have a few dead cells there in the middle, but most of them are alive. Now they chose Streptococcus mutans on purpose. Strep mutans are always associated with decay, but they chose them on purpose because Streptococcus mutans create the thickest, gooeyest slime layer that they knew they could grow in the lab. So it's testing two things. Could the peroxide product cut through the slime, and then how long does it take to actually kill the cells? 5 minutes is not enough. In the middle image there, that is the same strain of biofilm, same growing conditions, but the hydrogen peroxide gel, the 1.7% concentration, has been applied topically and left in place for 5 minutes. 5 minutes is not enough, but 10 minutes is pretty good. You get almost 100% kill rate in 10 minutes. But note, it's not 100% of all the bacteria. It's 100% of the bacteria that the gel has come into contact with. So the exterior layer of the biofilm. Biofilms are almost always shaped like mushrooms. They have channels, and it's really fascinating, the whole development of a community or communities. But imagine that your bacterial community is like an onion with a lot of layers. When you use this tray and it's sealed and it pushes the medication down deep into the periodontal pocket and holds the medication, in this case the hydrogen peroxide gel, up against the bacterial community, what will happen in 10 minutes is a great kill rate. Peel off the outer layer of your bacterial community. Now, as soon as you take the tray out of the mouth, then what? It grows back. Hit it with your second treatment of the day. Peel off the regrowth in the next layer. You get up in the morning, most maintenance patients are going to start twice a day. 15 minutes is ideal, but right now we're on 10 minutes. In the morning, you get the regrowth. At night, you get the regrowth in the next layer. So you are going to kill bacteria with every single treatment. You will decrease the bacterial load in the periodontal pocket, but that oxygen is super important. It is the best way to create a healthier environment, and this is why we recommend 15 minutes. So 10 minutes, you get 10 minutes of debridement, 10 minutes of oxygen. 15 minutes, you get the debridement plus you get the full 15 minutes of oxygen. This gel takes a little longer than 15 minutes to completely activate and release all of the oxygen gas. Now your body will absorb it, but if you can go the full 15 minutes, you get the full 15 minutes of the oxygen therapy. This oxygen therapy is key. The oxygen is toxic to the anaerobes. It's going to put their regrowth on the defensive. The oxygen also helps stimulate the formation of new blood vessels. Oxygen under pressure will help stimulate the formation of new capillary beds. That means you're getting more oxygenated blood there. That means you're getting what the body needs to fight the infection. It's also true that when you get below a certain oxygen threshold, your white blood cells, your macrophages, do not work effectively. There is a therapeutic threshold below which they don't work. Add some oxygen, create an oxygen-rich environment. You're creating the right conditions for the body to do well. So let's look at controlled clinical trials. So here we're looking at pocket probing depth reductions, and these are 2 controlled clinical trials. The first one was 6 months, and it was just testing scaling versus scaling in the tray delivery of peroxide. And you get almost a full millimeter improvement with the adjunctive therapy added to scaling. In the second 6-month clinical trial, they had 3 arms, scaling alone, scaling with the adjunctive use of the trays and peroxide, and the third group had trays, peroxide, and doxycycline. You'll note adding the doxy did not give you better pocket depth reductions. The antibiotic is not used ever in a prescription tray to reduce pocketing, because the clinical experience over the last 12 years and the controlled clinical trials show you don't get any better pocket depth resolution. It looks actually like they did worse. That's not true. There's no statistically significant difference between those 2 groups, but adding the antibiotic doesn't help. It's the hydrogen peroxide alone that did a really good job of decreasing pocket probing depths. Now these are deep pockets, greater than 5 millimeters. In these particular studies, those pockets ranged from 6 to 10 millimeters. Now, I want to put this into context, and all of these references, and by the way, I'll have my email up here towards the end. If you want access to all these references, I'm happy to send them to you. They are not included in the research and publication handout, but essentially the top 2 are different and are not included in that handout, but the rest are. All right, let's look at pocket probing depth reductions. In general, I want to put my almost 1 millimeter stat that I just gave you into context. This is a monster study, all here, all of these arms. It was an 8-arm study, really well done, and you're testing a lot of different therapies against scaling alone. So quickly, scaling versus scaling and tetracycline fibers, scaling versus scaling, and this is metronidazole and amoxicillin. Next one is amoxicillin and the fibers. Scaling and surgery and the fibers. Scaling, systemic antibiotics and surgery, and then everything added. Now this is greater than or equal to 5 millimeters. In my last data set, I gave you greater than 5 millimeters, so we'll adjust that. But you see the range. It's hard to get an improvement over scaling alone. When you put in minocycline spheres, you get a 0.24 millimeter improvement. And by the way, every subject in the study had, on average, 31 spheres of the minocycline per visit. That is an average of 93 minocycline spheres in this study per patient. And then you put this into context and you adjust, the statistician adjusted these so we could give you a real number and compare it to some of the others. So it's a good comparison. When you look at perio studies, it is often noted that bleeding is recorded. It is very rare that bleeding is reported in the publication. Part of that is because publications have some serious limitations on what you can include. But I want to give you our bleeding on probing reductions for these controlled clinical trials. They're whole mouth scores, it's presence or absence, not severity. And what you're looking at are initial treatment versus 6 months later. And just know, in these particular clinical trials, they did not do perio maintenance. You should do perio maintenance, but they did not. And you can see that the benefit of adding the antibiotic came with the bleeding reductions. So the antibiotic that we often recommend for really serious bleeders, someone who's been coming to your practice for years, 3 or 4 month maintenance therapy, and they just can't keep it under control, the hydrogen peroxide and the doxy might work the best for them. And that's not to say that the peroxide alone isn't going to work. It's just going to take a little longer. If you want that wow factor, adding a couple of drops of doxycycline in the tray with the peroxide is really beneficial. All right, but there are times when the tray therapy is not going to work at all, and these are the times when it might happen. If the patient's not compliant, almost all patients who are paying for this are pretty compliant in the beginning. It could be that the seal leaks. In that case, that is possible. I'll talk about when you need to check to see if the seal is holding or not. But it could be an occlusion issue. And I'm thinking, so let's put this into a treatment timeline. You do your initial therapy. Trays are used at home between office visits. You do a maintenance appointment, maintenance therapy. Trays are used at home between office visits. You do your second maintenance appointment. You're looking throughout the mouth and you've identified a couple of areas that have not responded well. Start looking for an occlusion issue when you might have to make that adjustment. Could be a cracked tooth, an endoperio lesion. Often it's subgingival calculus that is still there. Can't always get it out. Sometimes it's burnished. So go back and look. Hygienists who I know who have a lot of experience with this prescription tray therapy will say, I use it so that I can go back and focus immediately on the areas that I need to pay more attention to. But it also could be that the pathogens have evaded the epithelial tissue, and those, once they get inside the gingival cells, there's nothing you can do topically. You have to remove it. So if you pair prescription tray therapy with laser therapy or any other kind of surgical therapy, you can get very, very good results. And here's a study that I just want to talk about quickly. This is a long-term evaluation from refractory maintenance patients. A periodontist who began prescribing trays back in 2007. Periodontists typically do this. They put their worst refractory cases on these prescription tray therapy first, and bring them on. We welcome them. But in this case, there were 66 patients who had had one or more surgeries, and they just could not keep the bleeding down. And then when you added the tray therapy of hydrogen peroxide gel only, and in this case, the periodontist recommended that the patients use the trays twice a day for 10 minutes forever. What you see is a 50 to 85% reduction in bleeding on probing for these patients. And this reduction was noted at 6 months and kept out. So let's look at it a little differently. If you're looking at whole mouth scores here, approximately 63% of the sites were bleeding. These are after all the surgeries. Within 6 months, you drop down to 16%, and you're able to hold it out. This is an important point right here. At 6 months, you get what you get. If your patient's been using the prescription tray therapy in combination with your initial treatment and your maintenance therapy or surgery, and they've gone for 6 months, that's about the best you can get. You get what you get at 6 months. You want them to keep using the trays to maintain those good, healthy conditions. But this is about what you get. And the treatment worked equally well for smokers and non-smokers. We got one outlier here, one smoker who did not do well, but equally well for smokers and non-smokers. Now, really interesting to me, the periodontist asked his patients to use the trays twice a day for 10 minutes forever. Okay, of 66 patients, how many of them do you think did it twice a day? I was surprised, half. Now, it's self-reported, but 33 of them said they kept it up twice a day. These are highly motivated patients. They've been through one or more surgeries. They want to keep their teeth and they want better results. They did it. The other half dropped down to 1 time a day. Statistically speaking, there's no difference between the once a day and the twice a day users. However, the periodontist will say that those stats do not tell the full story, because some of the patients that were doing it twice a day dropped down to once a day, couldn't keep up, and had to go back to twice. So you might have any periodontists on the line who have really serious cases, and we don't know. It's possible that people are genetically predisposed to periodontal disease. They have some other chronic inflammatory condition, cardiovascular disease, type 2 diabetes, rheumatoid arthritis, something else that has that interplay, that inflammatory interplay. Most of your patients are going to be fine long-term at 1 time a day. You might have a couple who have to stay at twice. So let's really dive in and look at how we can use these. So in maintenance therapy, which is where most offices start, you probe, you take your impressions, and 3 weeks later you deliver these sealed trays. You ask your patients to wear them twice a day for 15 minutes. And typically patients come back within 4 to 5 weeks. You could do it as quickly as 2 weeks. But you're going to evaluate them. If they're doing well, you can drop down to maintenance 1 time a day at 15 minutes. So let's take a look here. This is a patient that walked in to a periodontist office. He had been to several other offices, and they had recommended 3 other offices, and they had recommended extracting teeth and putting in implants. And he's only in his late 40s. He didn't want to lose his teeth. 100% bleeding on probing, significant bone loss. But the periodontist said, okay, let's try. Let's see what we can do. Scaling first, and then prescription trays. That's his usual protocol. Patient says yes. 4 rounds of scaling, it's time for the trays, and the patient says, you know, I think I'm just going to brush and floss better. I'm not going to get those trays. And you can explain why you need them. Toothbrush, rinse, and floss really don't get deep enough, especially with bone loss like this and pocketing. And ultimately, it's up to the patient. So a year goes by, 3-month maintenance protocols. He's still bleeding at 25% of the sites in his mouth. At that point, he accepts the tray therapy. Trays are prescribed to be used twice a day at 15 minutes. He went from his last 25% bleeding down to 0. You do not always get to 0, but our goal is to get at least to single digits. 3 months after starting, tray therapy was started in April. This is 3 months later. And you can see how nice that tissue is. You also see, of course, the whiter teeth comes from the scaling procedures also, but also from the hydrogen peroxide. It will whiten teeth, which is one of those really nice side effects and why patients like to do it. Porcelain fused to metal crowns or other restored sites. You guys spend all this time and your beautiful work is then threatened by the foundation. The tray therapy will keep the gingival margins much cleaner, much healthier, keep those restorations lasting longer. Difference here between these before and after images is 1 month of tray therapy. This patient used both the hydrogen peroxide gel and the doxycycline just because of the heavy bleeding that had gone on for years. But 1 month. Now she can drop the doxy. She's going to stick with the hydrogen peroxide and 1 time a day. And again, you want patients to use it just like they do a toothbrush, actually. You want them to use it every day. Patients who've been through scaling and a couple years later, they're back to where they began. You see all the, again, the porcelain fused to metal crown margins are tough. Lots of bleeding, 101 bleeding sites. This patient was scaled in 2014. It's now 2016. She's recommended to have it again. She says no. 3 months later, they recommend scaling again. She says no. They got trained in this prescription tray therapy, offered her the trays. She said yes. This chart is taken on June 8th of last year. Trays were delivered on June 23rd, and this is what the patient looks like on the right. Just 2 weeks later, she used the trays 3 times a day for 15 minutes. So if you start with tray therapy before you do any mechanical therapy or any scaling, you want your patients to use those trays 3 times a day for 15 minutes if you can get them to do it. She did it for 2 weeks and went down to 7 bleeding points. And when it is bleeding, it's not so bad, not as bad. So again, trays are delivered with hydrogen peroxide only on June 23rd. Use them 3 times a day for 15 minutes until July 7th. So you can use the trays before scaling. In clinical practice, some offices do it always. They want to get the bacterial load down. They want to have the healthiest tissue possible. It really is a conservative way to do treatment to get that infection under control first. But in practice, a lot of offices are only going to do this for patients who are really phobic or who have systemic conditions, cardiovascular disease, type 2 diabetes, because for those patients, the bacteria that enters the bloodstream during the scaling procedure can be a health risk. For healthy patients, it's not a big deal. Your body will handle it in about 90 minutes. But for patients who are systemically challenged with inflammation, it's a really big deal. If you use the trays first, again, 3 to 4 times a day at 15 minutes for just 2 weeks. You can go longer, but we know 2 weeks to be very effective from the controlled clinical trials that you can get a statistically significant reduction in pocket probing depth and bleeding in just 2 weeks. Then when they come back in 2 weeks later after using trays and you do the scaling procedures, as soon as scaling starts, whether it's sides, quads, rarely full mouth, but sometimes it is, as soon as scaling starts, you can drop down to twice a day until their next recare visit. And then surgery, of course, if it's needed, or laser therapy if it's needed. And then maintenance long-term would be 1 time a day at 15 minutes. And this is your classic case of a patient who you might consider to have trays first, because he is scared. He has avoided the dentist for a long time. He's afraid of the pain. He's afraid, a lot of it might even be in his head. He doesn't have any paid time off work. He does not have any dental insurance. He does not want to be in your office. So they talked to him about wearing trays first. The benefit of wearing the trays with the hydrogen peroxide gel first is the hydrogen peroxide breaks down the protein chain, softens the calculus and the tartar, makes it easier to remove. It's more like material alba. It's much easier for the person doing the scaling. It's much easier and more comfortable for the patient. And if you can address the inflammation first, it's the inflammation that hurts, right? So you are already improving the patient's level of comfort just by addressing the inflammation. So this is what happened in this is a month of tray therapy. He was asked to use the trays 4 times a day for 15 minutes. He could not do that. He was an outside landscaper. It was spring in Oklahoma, but he did do it 3 times a day most days. For 3 weeks, they asked him to come in 2. Didn't work out. He came in 3. Then they did debridement. So what you see in front of 24 and 25, that's only possible because they did also do debridement. And then he used the trays for 1 more week. So again, 3 weeks of tray therapy, supragingival debridement, another week of tray therapy. Wouldn't you rather scale this mouth? It's going to be so much easier. And for the person doing this scaling, you have better visibility because the tissue's not bleeding all over the place. You have better access. The calculus that is remaining is softer. It's easier to remove. It's just easier to do the procedure, and it takes a lot less time. After scaling, you use the trays twice a day. And in honesty, he reported he did it once or twice a day, but this is at his next maintenance therapy. Now, here, you have a good idea that you might need a new tray. This patient's pretty obvious, right, that you might need a new tray. All of those inflamed gingival areas have subsided. The seals that were made for the original gingival contours no longer fit. So what happens is that they leak, and this is an easy case. You should treatment plan for 2 sets of trays. Now, that said, he got from the pre-treatment to the post-treatment image with 1 set of trays, and those are good results, but we could do better if we got a second set of trays. He opted not to get a second set, but he has stalled out. He went from 100% bleeding on probing to 27%. He's got a few 4mm pockets in the posterior and 1 5, so no doubt good results. But if you were to get a second set of trays, then we believe we could get that bleeding down to 0, or not 0 always, but single digits to almost 0. Once the trays leak, you no longer have a positive pressure environment, and you really need to examine them. So essentially, you bring them in, put some hydrogen peroxide gel in the tray, and look for it leaking. You all have the option tonight of getting your teams trained for free, and we'll go over all of those details with you in your individual team trainings. Other patients who can do really well with prescription trays, and you might really consider it for their health beyond their periodontal disease, is if they have systemic inflammatory conditions. You are looking at confocal microscope images, phase contrast microscope images, my apologies, from Dr. Bard Levy. These are of his own plaque samples. He has hereditary high cholesterol. He takes a statin to address it. He also pays a lot of attention to his own general wellness. He had prescribed trays for patients who needed adjunctive help in their periodontal treatment, and saw how good their results were. And he likes the phase contrast microscope because it helps patients visualize what they normally can't see. In his own, once he noticed his own samples were getting heavier, then he started using trays himself. And what you're looking at is a month after tray therapy started. That was all the bacteria he could find on his sample there. So he's experimented over the years, and most of his patients, he says, can handle and get really good results at 1 time a day. He personally uses them twice a day. And then you've got patients like this, right? This patient walked into Dr. Tim Pronger's office with an abscessed tooth, obvious periodontal disease. Dr. Pronger said, wow, you are really, you know, while he's getting him numb to take out this tooth, he says, we really need to talk about this. 100% bleeding on probing. If you're not careful, you're really increasing your risk for a heart attack. He's 34. He said, I already had a heart attack. He said, well, we got to think about diabetes too. He said, I'm already diabetic and I can't keep it under control. So they got to talking more about his general wellness, and the patient stayed with the practice and accepted periodontal therapy. So this chart here, where you see all the bleeding, was taken in April of last year. Impressions for the prescription trays were taken in June, and the trays were delivered in July. This particular office, given all of his other health issues, started with trays first. And so they used the hydrogen peroxide gel and the doxycycline. The doxycycline was vibramycin syrup. It's a product put out on the market by Pfizer. 4 times a day for 15 minutes, and have him come back in a month later. So here he is a month later. This is just tray therapy here. And this is what I mean when I'm saying that the hydrogen peroxide gel breaks down the protein chains in the plaque. You can see that it just makes it soften. It softens it up, makes it easier to remove. If people have really serious, like calculus bridges, it can soften it up so much that chunks fall out. You just have to tell them to expect this potentially, that it's not their tooth, it's the calculus has been built up. And this is, again, 1 month. What's really exciting was his systemic markers. His HbA1c before tray therapy was 9.3, and I've left you with your systemic markers there so you can see what that, put that into context for diabetics. Glucose off the charts at 220. 2 months later, before his scaling appointment, he was back in to have his blood work done, and his HbA1c was 5.8, and his glucose was way down. Now this is a big deal. So there's no real guideline to use HbA1c as a screening tool, but it does give physicians a good idea if somebody is diabetic and if it's under control. So he was up here past 9 when he started, and then down below here after he was done. But note the numbers. For every drop in your HbA1c, there's a corresponding 10% decrease in the relative risk for microvascular events. So it's a big deal to get that number down and to stay low. You're really improving your health that way, just decreasing the risks of other concerns. Scaling was done late September, and now you're looking at 3-month maintenance. I want to show you a couple of pictures here. This is obviously combined with scaling, and then continual tray therapy, and that beautiful pink healthy tissue. Struggling with implants, think tray therapy, it really can help. The same bacteria that are causing the infections around natural teeth can around your restored sites. This patient's implants were placed at the end of 2006. It's now 2014, and they're in trouble. So Dr. Jeff Goldstein is a regular tray prescriber, and he likes using trays first. And again, he recommended only the hydrogen peroxide gel in these sealed trays. Use them, the patient was instructed to use them 4 times a day for 15 minutes for 2 weeks, came back in, and then scaling started. And once that mechanical therapy starts, you can drop down to twice a day with tray usage. Now you're looking at 15 months later. I want to show you the pathogen report. Again, you don't sterilize the pockets, but you get really good reductions. I'm sorry, I said 15 months. This is 3 months later in maintenance. This is when that test was done at the 3-month maintenance appointment. Now you're at 15 months here. Good results, able to keep it under control. This is what we want, good long-term health. Your patients with halitosis, they are awesome candidates. If you do not have a halitosis program in your office already, you might consider it and make the tray therapy the cornerstone. If there, of course, there are conditions that are from medications that patients take or acid reflux or something like that that could be causing this, but a lot of times it's periodontal disease. You know your patients, you can smell them before you can see them. They will benefit tremendously from this prescription tray therapy. The first thing patients will notice within 3 days is a freshening of breath. If they've been using the trays, 3 days, fresher breath, and their loved ones will notice it too. You will be thanked. They will, if they know that they've been bleeding, then they should be able to visibly tell a reduction in bleeding, whether it's, you know, gums you can see, or if it's on your toothbrush or in the sink or whatever. And then within the same amount of time, 3 or 4 days, your mouth just feels cleaner. Whitening takes a little time because this is a low concentration of peroxide, but check out those teeth and gums. I want my gums to look like this when I'm 68. This is one of those refractory perio patients who were in the 68 patient study. He had a lot of bleeding after his surgeries, couldn't keep it under control, so the periodontist recommended the tray therapy twice a day forever. I don't know if he's a once a day or twice a day user. I didn't get that information, but that's beautiful. This is what we want for your patients. Really healthy gum tissue. They want white teeth, great, you can talk to them about it. If that motivates them to get their gums healthy, perfect, but you can do a lot of good for patients. And patients like the tray therapy. This comes from a 2013 controlled clinical trial where more than 40 patients were using the prescription trays. And you can see in all these categories that the trays, they had to, these 40 plus patients had to complete a evaluation about their usage experience, and it was compiled then. They were asked, are the trays easy to use? Did they cause any sensitivity? You have a range there. Are they comfortable, convenient? Did you notice whiter teeth, fresher breath? So you have a range of agreement there. 10 is the strongest you can agree. This is all unanimous agreement. But look at that last slide. Would recommend the trays to other patients. It almost got the highest agreement you could get unanimously. They really do like it. Who's a good candidate in your practice? For example, do you have a lot of geriatric patients? Do you have a lot of patients who come in with caregivers? Great choices. Anybody who's got a lot of xerostomia patients. I did not tonight talk about fluoride in the tray. That is the third medication that is often used, and it can be used for patients who have xerostomia or they have recurrent decay. There's a lot of, there's no clinical trial results on this. It's not been studied in this way because this tray was not anticipated to be used for fluoride, but in practice it is a lot. And it can, if you use fluoride in the tray, 3 20-minute applications in one day, it can knock out sensitivity. A lot of your perio maintenance patients have sensitivity already. This can really help. So let's talk a little bit about cost. The national average that people charge for a set of trays is around $700. That does not include any of the medication. You can see the range is huge, ranging from $500 to $1,200 for a set. And typically what's included in this cost is the impression visit, the lab fee, the delivery appointment, which is usually done by assistants or sometimes docs, but usually assistants, 30 minutes, and then a follow-up visit. There is an insurance code that documents the prescription tray therapy, D5994. We can send all of this information to your practice, so you don't need to furiously write it down. I think it's also in the handout there. You're going to code for each arch because it's for a carrier, and there is some coverage for it. Alabama is getting some of the best coverage in the country, but there's some good coverage also in Colorado, in Arizona, New Mexico, Utah. Kansas City Life just turned on the code this year. Companion Life, which does business as several other companies out west, has been covering for a while. Southland Benefit Solutions down in Alabama, they're all covering at $350 per tray. And you will benefit, your practice will benefit. So just look at these stats. This is one office. They prescribed 203 trays in 24 months. Their fee is right there, $375 a tray. And you can see how much they've made over time and how much on average they're doing per month for 24 months. And remember, this is with almost no doctor time. This is out of your hygiene department. Different practice, they charge a lot more for trays. They consequently have done fewer in 27 months here, but still good results. And then this one's up in Detroit, this office. Just good results, good hygiene production here. So it is now almost 10 till 8, and it is time to type in your questions. Here's a question right here. If any decay is present, do we need to try to restore first? So this depends on what you want to do and how you want to do it. With restorations, the question is, are you going to need a new tray? Inlays, onlays, amalgams, composites, even crowns, usually crowns, your gingival margins don't change much, and the original tray often fits, even with crowns. If you're going to be extracting teeth, if you're going to be you need a bridge or an implant, of course a new tray would be needed. So here's the question, do you want to get that tissue as healthy as possible first? I mean, you can see some really fast results in just a month and then begin the restorations. You can do the restorations first and prescribe the tray later, but if that gingival foundation needs to be really healthy first, then that would make sense to do the trays first. You're going to have to do this on a case-by-case basis, but it's a really good idea to get your gingival foundation in really healthy, and then you can do your restorations. If a patient gets tooth sensitivity with whitening agents, do they get sensitivity with this hydrogen peroxide gel too? And very rarely. There have been a handful of incidences, and because the trays are regulated by the Food and Drug Administration, anytime you have a concern, I personally am the one who gets to document it. So yes, we do have a handful of those over the last 12 years, but it's pretty rare. And usually it's in conjunction with one of two things. They're either whitening their teeth with some other agent, so you tell them to stop their other whitening treatments because they're going to whiten their teeth with this. Or it could be that they have a lot of recession, and you now have really clean root surfaces, and those root surfaces are sensitive. So because the hydrogen peroxide gel is such a low concentration at 1.7%, you really don't see it often. And honestly, we've got patients who want to whiten their teeth and they can't do it with the higher concentrations of peroxide, so they're using this gel for whitening. But if it happens, you either discontinue use for a day, and it usually resolves itself, or you can use fluoride in the tray. And again, 3 20-minute applications in one day can handle it. All right. Our new doctor likes using Arestin, but we haven't seen a lot of positive. Any thoughts on how to convince? Okay, well, there are good reasons to continue to use localized antibiotics, in this case Arestin. And the time that it would be really effective is if you have an acute inflammatory cycle, because most acute inflammation is caused by planktonic cells, and those planktonic cells are going to be really susceptible to an antibiotic because they're actively dividing. But if you haven't noticed a lot of good results, talk about the prescription tray therapy and really find out how to present this in such a way that you can talk about good patient health and the improvements that you can get with long-term usage, and then the other benefits, of course, that patients like, which are always the fresher breath and whiter teeth. Patients who are refusing any antibiotic therapy, in this case, great candidates. Anybody who's been through scaling before, been through a lot of localized antibiotic therapy before, and they're just frustrated by it, good candidates. You have options here. And it's easy for patients to say yes to this. It's cost effective for them. Trays last about 5 years. So it's a big upfront fee potentially if you're charging, some periodontists I know charge $1,200 a set. Their patients are weighing out additional surgeries though, so everything's relative there. But your trays should last about 5 years, and the national average is around $700 a set. It's like 50 cents a day when you average it out. Do you have training to make the trays in-house? And the answer to that short is no. The trays are regulated by the Food and Drug Administration, and so they have to be manufactured or fabricated in a lab registered by the Food and Drug Administration. So legally, to have clearance to market this, you do need FDA clearance, and FDA regulations, because this delivers a drug, is really why it falls this direction, requires that they be manufactured in a lab with the FDA. Since the peroxide concentration is so low, and if there was decay present, the peroxide will not kill or damage the pulp and create endo, and the answer to that is correct. The peroxide will not kill and damage the pulp and create endo. Often when you're dealing with a patient who's got these really deep pockets, especially if they're vertical defects, you get them all cleaned up and then suddenly you discover, oh, there's an endoperio lesion down there. Sometimes this is a good way of finding those problems. I would say to you specifically, if you have a tooth that is so damaged, you need to extract it or restore it in those ways. You have every right and a good reason to do that first, and then use the trays if you want to. But there is no evidence that the peroxide kills or damages pulp or the endodontic area. Does Perio Protect have training on how to present this to patients and quickly? Yes, we have lots of training for you. We also have a lot of videos. You can go to our YouTube channel. We've got on our website, providers.perioprotect.com, under resources, there's a media page. We got lots of good information for you there. Okay, is Perio Protect appropriate for teenagers, for example, after ortho? Yes. Perio Protect is not particularly appropriate for children who do not have all their permanent teeth. That said, I have a 14-year-old who's been in trays since he was 8. He had his first endodontic procedure when he was 8. He's a chronic acid refluxer. His teeth are a mess. We tried varnish. We tried all kinds of things, and we went to trays, knowing full well that we were going to have to make several sets as he lost teeth and the permanent ones came in. It's not going to be something most parents are going to opt for. It was great for us. But teenagers, yes. And you know your patients. You can talk to them till you're blue in the face about healthy gums. And what they want to hear is whiter teeth. So if whiter teeth matter to them, especially to those teenagers, you tell the teenagers you got a whitening agent for them, and you explain to the patients that you've got this great way to get this disease under control, especially after ortho. Great time to do it. We have had a couple of cases. We've tried to make ortho over brackets. It's not easy. It does not work well. The impressions are very difficult also. So I would not recommend it during ortho with brackets, but sometimes when your patients are ortho so bad, the periodontal disease during ortho is so bad, you have to remove the brackets, do this tray therapy for a couple of months, and then put the brackets back on. We've done that for patients. Any danger of using long-term Perio Protect damage or changing normal healthy flora? We, in 12 years, have not seen it. There is no data that indicates this. Hydrogen peroxide creates this healthy environment with oxygen. Really, this is oxygen therapy at its best. You are never going to kill all the bacteria. They're always going to grow back. What you want are the healthy bacteria that grow back, and those typically grow back in oxygen-rich environments. Next question, is this product safe for full mouth cosmetic restorations? This product is excellent for full mouth cosmetic restorations. I would recommend you do the tray therapy first. Get your gingival foundation under control. Know where your gingival margins are going to be. The teeth are already going to be beautifully clean and healthy because the hydrogen peroxide that manages the biofilm subgingivally also does it supragingivally. You'll have beautiful healthy teeth, and then you'll know exactly how to do that cosmetic restoration. All right. I do not see any other questions in, so I want to thank you all. If you do come up with questions, email me.